Hi friends, I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI, so I'm a fertility doctor. And every single day I talk to patients about their health, hormones, their fertility, and about pregnancy loss. I experienced pregnancy loss myself, having 4 miscarriages before I had my 2 children. So this is a topic really near and dear to my heart. And one thing that I find very commonly is that many doctors are really quick to dismiss pregnancy loss because ultimately it is overall common, and often there is no direct or identified cause besides presumed abnormalities with the embryo. But that doesn't mean that you have to take that as just the answer. And specifically, if you're having recurrent or repetitive losses, you've got to be an advocate for yourself. So even though that might be the most common cause, is that what's going on in your scenario is always a big question. So I always think it's important for you to understand what's going through my brain when I see somebody who's having pregnancy loss. And this can help you in your evaluation of your own situation and what questions to ask your own care team, because ultimately medical care is personal, especially when it comes to pregnancy loss. We all have a unique situation. Before we jump in, just huge thanks for all your support on the channel. As always, so thankful. Would love it if you would subscribe, like, share, comment. We get a lot of our next topics from your questions and your comments down below. Officially, a chemical pregnancy loss is a pregnancy loss that you get a positive pregnancy test. So HCG is being made in your body, but you have never had an ultrasound that documents the pregnancy inside your uterus or sees the pregnancy at all. You start miscarrying beforehand. So this is the scenario where you might get a positive test and then you start bleeding maybe a week or so later before you ever go see your doctor, or too early to detect anything on ultrasound. This is representing a very specific time during implantation for both the embryo and the uterus and the environment, and it might represent a different slew of problems than if you're losing pregnancies later on, because that might represent something differently, having an empty sac, or having a baby that looked normal and then lost the heartbeat, or even getting into the second trimester. So we start actually thinking about different things depending on how far the pregnancy might progress. So we're going to go through a list. Of course, you might hear the statistic that up to 25%, 1 in 4 pregnancies are going to end in miscarriage. The odds of pregnancy loss increase as you get older. So that's just really important to know. If you're 40 and you're trying to get pregnant and you see a positive pregnancy test, you're going to have a 50% chance of having a loss due to chromosome issues. And that's because the number one cause of a chemical pregnancy loss is going to be chromosome abnormalities of the embryo, most of these associated with age-related aneuploidy, meaning as women get older, the chromosomes inside their eggs start to move positions, is the easiest way I like to think about it. Imagine your chromosomes are lined up inside your egg and they're kindergartners in order, alphabetical order. The longer I ask them to stand that way, the more likely somebody's going to get out of line. And so if we think about this, if you're 40, they've been sitting there for 40 years. And so we have an increased odds that somebody's out of line, just leading to failure when the embryo is developing to be able to do everything that it needs to do. And so this is going to be one of the top causes. So number one, we've got chromosome abnormalities of the embryo. Most of these are random and due to age. However, there is something also called a balanced translocation, and this is where 2 of your chromosomes have swap spots, and this could be either maternal or paternal in origin, and you don't really have any symptoms until you start trying to get pregnant and you're having repeated pregnancy losses. This can be diagnosed with what's called a karyotype of your own blood, so checking your blood to see if your chromosome is 46XX, 46XY, or if you have anything that has swapped positions. So that usually is a test that we recommend. But importantly, there's no test for random aneuploidy or random genetic abnormalities beforehand. You can test if you've had the pregnancy loss and you have the miscarriage contents to see if it is genetically abnormal. But by definition of a chemical pregnancy, we don't have that to test. So sometimes we might say this is the most common, the most likely scenario, but there's no way for us to know if that's really what caused it or not. Second is going to be poor embryo quality, and we're going to correlate this to poor egg or poor sperm quality. Remember that an embryo needs to be genetically normal, yes, number one, but number two, It has to have the competency. The cells have to divide, the organs have to form, turn into a baby, and your body is not supposed to allow just anything to implant. So if that embryo is not giving the right signals back, what is going to happen is it's not going to be able to keep up growth. It's not going to be able to secrete enough HCG to stimulate enough progesterone. And it's going to do what it's supposed to do, which is tell your body that it should miscarry if it can't keep up. Now, a lot of egg and sperm quality can be related to maybe lifestyle or environmental factors, can also be related to age. Sometimes it's also just random, but people who go through IVF really know that this one is a CHOP cause because all genetically normal embryos do not implant or become pregnancies. And so that is just telling us that it takes more than genetics to become a baby. Number 3, speaking of progesterone, is going to be low progesterone, luteal phase defect, issues with ovulation. So remember though, something else is causing this problem. So progesterone is really important. It opens and closes that implantation window. It is made from ovulation. Do not take progesterone in your follicular phase. Your body does not have progesterone then. That is an estrogen dominant phase by nature. But once that corpus luteum starts making progesterone after ovulation, you're on a certain clock to open and close the implantation window. And we know that low progesterone levels is kind of a chicken and egg thing with pregnancy loss, because if the pregnancy is not dividing normally, it's not making enough HCG, it's not stimulating as much progesterone to be made, and that's part of how you should miscarry. But the opposite can be true too, that if you're having an ovulation issue, and if the first stage of ovulatory dysfunction is a short luteal phase or failure to make enough progesterone or have a corpus luteum last long enough, you could be in a position where maybe your ovulation issue is causing a luteal phase issue and not enough progesterone. Again, we want to try to get to the root cause. I like to treat a lot of this with ovulation induction. Progesterone's not wrong, but there's a little bit more that's going on here. Number 4, speaking of, let's say endocrine and hormonal issues. So in the same context, what all can cause hormonal or endocrine issues? Well, we've got thyroid disease, we have prolactin abnormalities. You also can have ovulatory issues in the context of having hypothalamic dysfunction, even PCOS. You can also see insulin resistance playing a role when it comes to endocrine issues that can contribute to early pregnancy loss. Number 5 is going to be autoimmune issues. So autoimmune disease itself can cause a lot of inflammation, and autoimmune disease has been associated with higher rate of pregnancy loss, especially if it's uncontrolled, undiagnosed. That doesn't mean that there's an easy catch-all panel for every autoimmune disease. It can be very hard to diagnose autoimmune disease. You often have to get quite sick to get to that level. But things like autoimmune thyroid disease definitely correlated with early pregnancy loss. Things like celiac disease has also been shown. Things improve if you take gluten out of your diet for celiac. Things improve with autoimmune thyroid disease if you're on Synthroid. So this is something to think about, especially if you have autoimmune disease in your family. Next is going to be clotting disorders. So clotting disorders, if you have something called a thrombophilia, means your blood is more prone to clot. This can be autoimmune, like antiphospholipid antibody syndrome, but there's some other clotting disorders. They can run in families. You might know about this because you might have developed a blood clot in the past or been told not to take birth control pills. But getting pregnant predisposes you to have even more blood clotting. A lot of times, the recommendation is not to screen for all of these because they're not a common cause of early pregnancy loss. Typically, it's a later pregnancy loss that you're seeing, but it is something to think about. And if there's anybody in your family who's had blood clotting issues, definitely bring that up. Next is going to be inflammation in general. So inflammation is a really underlying issue when it comes to insulin resistance, autoimmune disease. But inflammatory behaviors themselves can contribute to pregnancy loss. So things like cigarette smoking, heavy alcohol use, marijuana use, even, toxins in our world. So this is where you can actually probably make a big difference by taking control of what you can and looking at your life and trying to have a less inflammatory lifestyle. And this goes for both you and your partner. Even partners who use marijuana have a higher rate of pregnancy loss than the female partner. So male partner using marijuana can contribute to pregnancy loss. So it's changing sperm quality, changing the DNA in the sperm, causing inflammation that is contributing. So we can't discredit partner factors as well. And then last is going to be uterine issues. And this is big, but it is important. This could be birth defects, scar tissue, polyps, which can cause inflammation inside the uterus, fibroids inside the uterus, something called endometritis, which is just an inflammation inside the uterus. And so this is something to think about, especially if you're having repeated pregnancy losses. We want to make sure we're doing a uterine cavity evaluation. So a lot of this evaluation is going to include different types of hormone testing, so blood work, but we're also going to want to do an evaluation of your uterus, the inside of the uterus specifically, so not just a regular vaginal ultrasound, but like a saline sonogram, something where we're putting something into the uterus to look around. And we also want to do a semen analysis because the sperm quality can impact this as well. So we want to check your ovarian reserve, your hormones, think about clotting factors, think about endocrine issues, think about autoimmune, especially if there's anything in your family, karyotype, and then of course the anatomical evaluation, the semen analysis. So there's a lot of things to think about there. A lot of times you heard me say your situation or family history, and that is why a good menstrual history, understanding your family history, and really your doctor can only use the information you give them to go on. Don't discredit if you've had repeated pregnancy losses. I've seen some doctors totally discredit them. I count them. They are pregnancy losses. So bring them up to your doctor. If you're having multiple of them, don't settle for a no workup. Find yourself a fertility doctor or somebody who will give you a proper evaluation. Sending you lots of love. Thanks again for all your support. Hopefully this video is helpful. Ask questions in the comments. And as always, you can get more information on